Okay, hello, David. How are you doing?
Yes, I'm doing great, Albert. How you doing?
Good, good, doing fine. So, you're going to speak in November, and you're going to speak about something that, if I'm right, I'm not as involved in this as you may think, but I think you talked about breast cancer in November. Is that correct?
Yeah, I'm gonna present a couple of lectures. One of them is going to be on thyroid and the elements, and
Okay.
what we do with that is dig a little bit deeper into the way thyroid hormone is made and how it is functioning with regard to the iodine that's incorporated into the thyroid hormone, selenium, the importance of selenium, and getting adequate amounts of selenium, because the deiodinases, that is the enzymes in every cell of your body that will convert T4 into T3 are selenium dependent enzymes. So we're going to talk a lot about that. I'm going to also talk about how environmental pollution such as arsenic and mercury can bind up selenium and remove it and prevent it from getting incorporated into the deiodinases, and that can kind of wreak havoc on how your body is able to actually not only synthesize thyroid hormone, but also convert the more inactive T4 into T3 within the target cells, which is every cell of your body. So that's what I'm going to talk about with regard to the thyroid and the elements. And then with the breast cancer lecture, what I'm going to talk about are estrogen metabolites. That's something I've been talking about for the last 20 years, as you're well aware. And so I'm going to talk about the way the estrogens are metabolized, and probably most of the people that are listening understand that the estrogens are metabolized down different pathways. They can go to different kinds of catechols that are 2 catechols that are safer as opposed to 4 catechol estrogens that are more toxic, more genotoxic, and can lead to increased risk of cancer. We now have developed a dried urine test where we can look at these metabolites of estrogen, look at their content, how much is being made, and also we're looking at the same time at not only the estrogen metabolites, but also what's happening with the androgens and what's happening with cortisol. We're looking at a diurnal cortisol profile also, and in cancer patients we know that tends to be flat. I know, Dr. Taylor, you talk about that in saliva. We see the same kind of thing in the urinary free cortisol. We've just developed a melatonin assay in the dried urine, so that what we see is that is pretty much inversely related to what we see with cortisol production. So when we look at first morning urine melatonin, we're really looking at the melatonin that was produced during the night. Your first void is going to tell you whether or not you're making adequate levels of melatonin. If you don't make enough melatonin, a lot of things are going to go wrong. So in particular, cancer patients make much less melatonin, and we're seeing that in some of the breast cancer patients we're looking at. So the cortisol profile tends to be flat, just as we see in saliva, and the melatonin is really not being produced in very high amounts relative to the average individual, healthy individual. So those are some of the things that I'm going to be talking about, and of course elaborate extensively on those subjects that I just mentioned, both thyroid and elements as well as the estrogen metabolites. So that's what I'm going to lecture on. And of course, I started in the lecture in March on testing and the different types of methods of testing, both saliva, serum, blood spot, and urine testing, and talked about the pros and cons of that. And so if anyone has any kind of questions they'd like to ask regarding those issues, feel free to blast away. I love the tough questions that people ask on these kinds of things, and it helps me think a little bit more about how to direct the research that we're doing at ZRT. So that's in a nutshell, without giving away everything, what I plan on presenting.
David, let me ask you, when you do a dried urine on cortisol, I mean, do you do a spot urine 4 times a day, or is it a 24-hour?
Yeah, what you do is you basically you pee on a strip, or you dip it into a cup that you pee into, and so we look at it at 4 times during the day. We look at the first void, and then we look at the second void, which is about 2 hours later. And that actually gives you've heard of the cortisol awakening response. What we see in individuals is that second void, cortisol is going to be the high point during the day, and then it should fall back down by 4 o'clock, which is the third sample we collect, and then we collect one right before bed. So what we see is very consistent with what we've seen in saliva. The advantage of the cortisol, the urinary free cortisol, is we're using that same sample to that's basically extracted. Once it's dried, then it comes to the lab in a dry form. That's then extracted off the paper, and we measure the cortisol as well as the cortisone as well as melatonin in those samples. And then we also use those 4 samples, combine them, and measure the estrogen metabolite. So people have different options of what types of things that they want to test, but yes, it is a dried urine test, and it's the same dried urine we use for looking at the elements. We're now looking at iodine, we're looking at bromine, selenium, arsenic, and mercury in that dried urine sample.
So, do you think you get a good idea? Because one of the somebody had a question about this. So, do you think you get a good idea about the elements, even though you don't do any provocation, or are these elements that you don't need to provoke?
This is not a provocation assay.
Okay.
It is, we're not using anything to try to get the body to release the heavy metals. This is a baseline. So we've established baseline levels, and people who have excessive levels or inadequate levels of different elements, you'll see that in the urine profile. I would say that the two, there are a lot of people that have iodine deficiencies in the samples that we're looking at. I'd say 10 to 20% of the people here in the United States. In certain areas of the world, it's like we're getting samples from the northern European areas, and they're almost all low in iodine, and that's pretty much what's known. And so different places around the world. It is the advantage of the dried urine is it allows us to get samples from anywhere, because once the urine is dried on the filter strip, you just let it dry overnight. It's stable for months. So we can do whatever people are able to analyze in urine, we can pretty much do it in that dried sample. So the analytes are very stable, that we can analyze them by those methods. But I'd say that the biggest problems that I'm seeing right now in the urine are low iodine, low selenium, and more elevated arsenic levels. And I think the arsenic it can be present in people's well water. With fracking going on today, it's releasing the heavy elements like arsenic into the water systems around the world. That's a big problem. Arsenic poisoning is a huge problem in India, where they've dug tube wells in Bangladesh. So people are getting overexposed to arsenic, and I'll talk about that in the lecture. The problems with arsenic, excessive levels of arsenic.
That's interesting. I didn't know you were doing all that, Dave. You gotta stop hiding these things. I didn't know you could do all that with dried urine. You yeah. So then what you're testing on the urine, looking at thyroid, you're primarily looking at the elements that affect thyroid. You're not necessarily you look, but you look for mercury and stuff too, right? Is that what you?
Yeah, we're looking at the elements with regard to thyroid, and we have a complete, what we call a complete thyroid panel, which is you do a blood spot, so you can look at total T4, free T4, free T3, TSH, TPO, thyroid globulin, and then so it's a dried urine and a dried blood spot, and then dried urine we can look at iodine and bromine and selenium, arsenic and mercury, and I'll talk about the interactions of all those things, the importance of being able to look at all of those things and try to figure out, okay, what might be going wrong with the thyroid. It's, you know, as I say, as I dig deeper into thyroid function, which I'll talk about, realize that certainly knowing something about iodine levels, knowing something about selenium levels, often what we'll see, and people are taking excessive amounts of iodine, and I'll talk about that, is that it causes what's called a Wolff-Chaikoff effect, and their TSH jumps really high, and their thyroid globulin goes up. And the thyroid basically stops making thyroid hormone. So if you're not taking thyroid hormone and you're getting excessive amounts of iodine, that can cause you to become very hypothyroid, and people, they can get goiters. They have all sorts of problems with excessive amounts of iodine, and I'll talk about that also.
Okay. So do you see the screen? Am I on the right page?
Yes.
Okay. So you have these two profiles.
Right.
Let me see.
Yeah. So the profile, the second one there is the blood spot and urine. So you can see all the different things that we're measuring there.
Go here.
And mercury is an add-on test to that if you want to look at that.
Okay.
That's not commonly problematic in the non-challenge sample.
Mm-hmm.
If it is, what you see in urine as far as mercury goes is pretty much how much you have in your kidneys. And even with provocation, you're looking at the mercury that's released from the kidneys. You're not looking at necessarily methyl mercury that's released from the brain,
okay,
which is more problematic. But it
right.
gives you a good index of the body burden of these elements.
Okay. So all right. So I'm trying to see if anybody. We've got plenty of people on here. I don't see any hands raised. Let me see if I see any. If people have questions. Okay, Dr. Zava. Ellie, you want to say something? I see a question. Hold on. Let me unmute you. My good friend Ellie Campbell. Ellie, are you there? Hello, Dr. Campbell. I unmuted you. Okay, well, I'm going to ask her a question. She chatted it, so maybe she's having some trouble. Dr. Zava, have you seen a lot of buzz in recent literature about the 2:16 ratio not being helpful like we thought it was? And in fact, the ER/PR breast cancer patients, a cohort of the WHI, who had the highest and most favorable 2:16, had triple the risk of getting hormone-negative cancer. If you can't answer now, will you talk about this in November? Authors suggest it is time to abandon the 2:16 ratio for testing.
Yes, it definitely is time to abandon the ratio, and I will talk about that. Okay. What I find in breast cancer patients is that the 2 and the 4 hydroxy tend to be elevated together. The 2 is not as mutagenic as the 4. 4 is the most dangerous. That's for certain.
Right.
But the 16, people have thought that the 16 is problematic, but actually it isn't. And it never made any sense to me that it was, because 16 is on its way to estriol. And we all know that estriol is the safest form of the three sister estrogens, estradiol, estrone, estriol. Estriol is like a burnt match. You can't light it again. It's not going to start any fires. It's not going to cause mutations in the body. That's why it's made in such high amounts during pregnancy. And there's actually a very interesting paper that just came out on estriol, if you all search the literature, on estriol being beneficial for preventing platelet fibrin reactions and blood clotting. So it prevents it. So as opposed to estradiol or estrone having, stimulating those effects. So estriol is quite safe, and I think it should be reconsidered for forms of estrogen replacement therapy, particularly for vaginal atrophy, vaginal dryness. I know, Dr. Taylor, you use it like this for.
Oh yeah, for vaginal dryness and atrophy. It works like a charm. I mean, it works 95% of the time.
Yeah, and the interesting thing about that paper is it says it's safe and actually prevents blood from clotting. So it's the platelet formation.
Mm-hmm.
So it's a strong paper.
Yeah. So so now in your blood spot, I mean, what? Well, I don't want to give it away. So you're looking at more of the unmethylated 4-hydroxys and the quinones and all of that stuff.
Yeah, what we look at in the dried urine is and we do this by GC tandem mass spec, is we're looking at the 2-hydroxyestrogens which are 2-hydroxyestradiol and 2-hydroxyestrone. We look at 4-hydroxyestradiol and 4-hydroxyestrone. Right. We look at whether or not they're methylated well.
Right.
Because sometimes we'll see that a person will have, for example, a high 4-hydroxyestrone or estradiol, and that's not good. And it's especially not good if a person is not methylating them well. So we also look at the methylated forms of these 2 and 4-hydroxyestrogens. So let's say, for example, a person has fibrocystic breast disease, and I was just looking at one yesterday and closing a report, and they have low levels of 2 and high levels of 4, and they're not methylating well. So their 4-methoxy estradiol is low. That's not good because that means that 4-hydroxy can spill down into quinone estrogens if it's co-oxidized by transhydrogenated fats, for example, or some other reactive, some other free radical reaction that's going on in the body. So that can spill down. It can bind DNA. It can cause mutations that can lead to cancer. And we know that from the literature. So we're looking at the ratios of those things, and that's the bad news. The good news is that if we know that, we can tell people that they can do things to prevent that from happening, such as iodine will be, is one of them. Certainly, use of cruciferous vegetables. These are things that, Dr. Taylor, you talk about all the time in your lectures with regard to, the 2 and 4-hydroxyestrogens. So, and I'm sure you're going to be talking about that again. So, but those are the, that's the good news, is that you can change those things. You can lower, the estrogen burden itself. You can use progesterone because it's going to push things in the direction of good metabolism. You can eat right. And those are kind of the things that you already know that you should be doing. It's just reinforcing. It's looking at these metabolites and saying, hey, you have a genetic risk for making more of these kinds of things, and you need to lay off the transhydrogenated fats. You need to lose some weight. You need to be exercising. You need to be eating good, healthy foods that are not going to cause the formation of these these bad estrogens. Some people, they have galvanized genes, and they can do all the bad things to themselves that they want, and they manage to live to be 90 years old, but that's not most of us.
Yeah. So, okay, well, Ellie, she says she's on now. Let me just make sure we don't want to answer too much of a question, since we want to make everybody come. Ellie, hold on, I'm sorry. So then we'll move on. Ellie, you're there now?
Yes, I am here now.
Okay, did he answer your question?
He did. So
okay.
I think that's actually pretty exciting to think
yeah.
that we're ready to abandon the 2:16 ratio as a test that we do in the monitoring of our hormone patients. I mean, that's pretty practice changing for a lot of us. So it's exciting to hear that we're keeping up with the literature.
Yeah. Dr. Zava, I was like you. I would see that 2:16 ratio, and I've learned most of this stuff from you, and then when I look at it, I'm like, okay, what's so bad about the 16? And I know the 4 is like the biggie, and
right.
I used to always wonder why we looked at the 2:16 ratio, and then it was the 4 hydroxys that went to the quinone. So this makes more sense to me, and so it's good that the literature is kind of helping my natural logic to feel better.
That's been my natural logic for a long time.
Yeah, because I always say, you look at the pathways and they'll tell you what you should and should not do, and you just and that pathway said, hey, there's nothing wrong with that pathway.
Right.
Why are we looking at that? So okay,
going
so
back to
that's great.
Dr. Taylor, going back to fundamentals.
Yeah, just look at the pathway. It'll tell you exactly where you need to go. So, okay, Dr. Zava, we appreciate it. His lab, I'm on the page here, but it's zrtlab.com. You used to have salivatest.com, but I see, like everybody should be growing, and you are constantly growing. Do you still have that salivatest.com?
I have to talk to my marketing people.
yeah, because you've gone much further than salivary testing.
Oh yeah, it's still a great test, and that's the majority of what we do, and it's definitely something that you can use to look at the bioavailable amount of steroid hormones that are circulating in the body. I just tell you real briefly, and we're not quite ready yet, but we've also developed a LC tandem mass spec methods for looking at salivary hormones, and we're going to really expand the panel of those things that we can test. We can actually look at things like anastrozole. We can look at pregnenolone. We can look at androstenedione. A lot of things that we haven't been able to do with our immunoassays in saliva. So look at DHT and testosterone, and it's a whole lot of different things that we can do by the mass spec method. So that I expect by fall we'll probably be launching that. So maybe when
you can launch it at our you can have the debut at the AFMA, and we'll
So I'm excited. I'm excited about that.
Yeah.
Particularly for guys who are using
testosterone
in combination with anastrozole, because we can actually monitor the amount of anastrozole. We can look at how much estrogen, how much estradiol and estrone they're producing, relative amounts, because you don't want that to get too low. You don't want it to be too high. So it's a really nice test to be able to look at all that.
And I think that's very important with all of these lawyer commercials about did you take testosterone. And the problem is these are people who are converting it to the wrong things, DHT and estrone and estradiol.
See, we can see that.
Yeah.
We can see that in the mass spec, LC tandem mass spec test that we're doing. So that's fully developed, and so it's just a matter of getting it to market. Now we're working on a little bit on ranges. And as soon as we establish those ranges, then we'll launch it.
Oh, great. Well, all right. Well, Dr. Zava, I thank you, and I just want everybody to know that 90% of what I know I've learned from listening to Dr. Zava over the years.
That's not true.
No, it is.
I would say 90% of what I've learned about the clinical aspects of these things I've learned from you.
Well, good. Well, it's been a good mutual learning relationship, and I've enjoyed it. And again, I see you're growing, and I always talk about it. If you're not growing, you're dying. And ZRT and Dr. Zava, they continue to grow and do more and more things. So they're definitely not dying. So again, great to talk to you. I'll let you get back. I know it's early out there. You're probably trying to finish up the day, and then we're going to. Now you're welcome to stay because Dr. Burdett is going to be next on the HIPAA rate. But again, thank you for coming. We look forward to seeing you in November. And again, it's zrtlab.com, and you can just look at the array of tests that Dr. Zava and his lab offer. Okay. All right, David. Thanks a lot.
All right. Take care.
All right. Okay. Bye. All right, Dr. Burdett, here we